Dr. Douglas's background, he's with Wake Radiology Consultants. He's a native of Springfield, Missouri. He earned his undergraduate degree from Cornell and his medical degree from the University of Virginia. He completed his diagnostic radiology residency at the University of Colorado in Denver. He completed an MRI fellowship at Long Beach Memorial Hospital in California. Prior to joining Wake Radiology in 2000, he worked as a diagnostic radiologist in Birmingham, Alabama at the Norwood Clinic and Caraway Methodist Hospital. Today, again, Dr. Douglas will be discussing coronary artery CT angiography for the evaluation of chest pain. Of note, Dr. Douglas has no conflicts of interest to disclose, nor will he be discussing any product under investigation. Please join me in welcoming Dr. Douglas back to Wake Med Grand Rapids.
Thank you very much, Dr. Perry. It's good to be back after, I think, 2 years ago was when we first presented at this conference some of our early results. And back in the winter of 2006, things seemed like they were picking up for this topic. In fact, we had been really working hard, even trying to get anyone interested in joining our research protocols that were going on at the time, up until about October of '05, when Oprah had her scan done on a 64-slice scanner. And immediately when that show aired, I had every single call was lit up on my phone bank, and I couldn't figure out what is going on here. We hadn't been able to get a patient enrolled for 2 weeks. And so there was kind of this drumbeat in the fall of '05 and leading up to when I had presented in this conference in the winter of '06. And I kind of thought we were on the verge of something big. In fact, I think it was at that lecture that I first made this slide and posed the question, is this thing ready for the prime time? Are we ready to see this in general, everyday clinical practice? And I think I was a little premature. In fact, we've seen steady growth in this technology and steady gains in the amount of interest. But I think for those of us that had immersed themselves early on, most of you out in clinical practice were not reading a Journal of Computed Tomography or Radiology. And we're seeing now, though, in the last year or so, a crossover from the technical journals into basic clinical journals. And we actually did a literature review for this, preparing for this talk, and I'm amazed how just in the last year you see a proliferation of interest in this in emergency room journals and general medical journals. So I think, again, we might be at a turning point. The other thing that once, again, prior to the Oprah show, I kind of lived in obscurity. No one really was that interested in what we were doing over in the CT lab. Since then, I get a lot of calls from both clinicians and the press, and I've been surprised. Again, I think I got so focused in on what I was doing, I was surprised how often people were confused about actually what we were doing with CT. So I think we just need to start from the bottom here, and what I want people to realize is today we're going to talk about a clinical scenario mostly where someone is presenting to your office or the emergency room with chest pain or shortness of breath, and we're going to try to figure out where CT might fit into that paradigm. But the first thing that I want you to be clear about is when a patient comes to our lab for a CT scan, typically we are performing 2 separate CT studies, 2 tests, and I want you, they're both very good and offer important information, but they're different. And I want us just to be very clear about that before we proceed further. So let's first talk about CCS, or the coronary calcium scoring. Calcium scoring is actually something that we do on almost all patients before we do the angiographic portion of the study. And this test actually can be performed in about 15 seconds. No IV contrast required. It's a very low radiation dose. And actually what we do is we scan the heart without contrast, and actually we find the calcified plaques. And we use that data to estimate their total plaque burden. And there's a proliferation of data out there. In fact, there have been over 1,000 peer-reviewed articles on calcium scoring in the last decade alone that show that your total plaque burden is highly correlated with your future risk of having acute coronary syndrome. Plaque burden highly correlated with acute coronary syndrome. The other thing that I want to convince you about today, and there's less literature about, but convincing literature, I think, is that the presence of calcium also predicts whether you have a stenosis. So the calcium score potentially can do two things for us. Number one, it can predict your future risk of having a heart attack. And number two, it also gives us some idea what the probability is that you're going to have a high-grade stenosis. Okay, now what is coronary? So let's contrast that now with coronary CT angiography. Okay, coronary angiography, and this is the sexy thing that gets in all the, you see it on TV, the spinning 3D hearts. What is it? Well, we give an IV contrast bolus, and we use CT to take very high resolution, thin slice axial cuts. We then take that data, put it into a computer, and make a 3D generation. Basically, we render 3D images that look very much like what you would see in the cath lab using that data. Now, the issue here is, again, we need IV contrast and we need very, very high quality images to make these 3D images. So the point is, the radiation doses are significantly higher when we're talking about coronary angiography versus coronary calcium scoring. And to give you ballpark figures, what does that mean? Well, it's probably twice as much radiation than someone would get who got a pulmonary embolus CT, or a similar amount of radiation that you would get from a nuclear thallium scan. So it's comparable to other diagnostic tests that we do, but it's a significant dose, especially when you compare it to something like calcium scoring, which is very little radiation. Okay, now what does it tell us? Well, we try to basically recapitulate what someone would see in the cath lab using a non-invasive technique. So what we do when we do the CTA is we're trying to find stenoses. But again, I want to be very clear about this. Long-term predictive probability is more a function of the calcium score than the CTA. The calcium score gives us a good prediction long-term. The CTA finds stenosis today. Okay, so now let's talk about calcium scoring. Again, what I just showed you was a stack of images taken from a CT scan. Again, people get all confused. They see these whiz-bang 3D images like we're going to show in a minute, or I showed it on the primer slide. But what they forget is CT, after all, is just a bunch of tomographic slices. It's the same CT we use for the abdomen, the brain, any other part of the body. So we can look at these data independently from the 3D renders that we make. And actually what we do with a calcium score is we actually find the plaques, the calcific plaques, and we count them up, basically. We look at all the plaques and we feed that data in here into the computer. And here is a plaque in the LAD that either I or the technologist has marked for scoring. And the computer then quantitates the total plaque burden, which, again, I want to be very clear. The calcific plaque, the amount of calcific plaque is a surrogate marker for your total plaque burden. We know from many pathologic studies that only about 20% of plaques calcify, but by the time someone has an acute coronary syndrome, typically they have scores, if not hundreds, of these lesions. So there's usually plenty of calcified plaque long before we see a stenosis or someone with an acute coronary syndrome. In fact, in autopsy studies, over 98% of patients that die of MI will have some calcified plaques in their coronary vessels. Okay, so what do we do with this quantitative number? Anyone out there know who Arthur Agatston is? No one? Wow. When I give this, oh, someone back there, yeah, Arthur Agatston. Right, the founder of the South Beach Diet. Well, before Agatston went on to greater glory and more important things, he spent several years, circa 1990, working out this plaque scoring system, this quantitative calcification scoring system that would estimate your total plaque burden. So the actual units that we use, the Agatston score, actually is named in honor of Arthur Agatston, who did this pioneering research. So, total plaque burden. If your score is 0, that means we don't see any calcification, no detectable disease, okay? Scores of over 100, usually we're getting into what we would consider the significant range, and scores of over 400, then you're talking about advanced disease. We see scores can range wildly. In fact, we had our all-time record about 2 months ago in our office, a gentleman with a calcium score of over 3,000. So we scores ranging all the way from no plaque into the thousands, okay? So you say, well, so what? You know, what does, again, we just need to be sure about this point. People say, well, what does a calcium score have to do with heart attack, okay? And are there any medical students here? Well, now, my second year of pathology, we had this lab that was called Man in the Pan. And they would bring out this bucket of formaldehyde with all the organs. I love this class. And you would like get your gloves on, and you would reach down into that bucket and pull some stuff out. And I remember the lab on MI. So you pulled this heart out of there, and you're supposed to like examine the heart. And of course the guy had like calcified rock. His whole coronary tree was just a calcified rock. And then they gave you like the little path slides, you know, where you saw actually the vessel was occluded and all that. And that really stuck with me. It was a great lesson. But unfortunately, what I learned that day turned out to be wrong. I mean, what I was taught, and probably most of us who are passing middle age into middle age or later learned in medical school, was that atherosclerosis was kind of akin to an old rusty faucet. Basically, your pipes got slowly clogged with rust over many years, and eventually this this tight, narrow area would occlude, and then you had a heart attack when that narrowing occluded. And unfortunately, that model of what causes acute coronary syndrome hasn't actually turned out to be correct. In fact, what we believe now to be true is that any plaque can basically rupture, okay? And plaque rupture is a very thrombogenic event. So let's say you have a plaque that's causing very little narrowing, 10% stenosis, 20%. When that plaque ruptures, that can incite a thrombogenic event, and you get immediate arterial occlusion, and that's what causes acute coronary syndrome. So the point is, what I learned that you needed this high-grade lesion to have a heart attack actually isn't true. And in fact, a stenosis is not necessary. And when we take patients to the cath lab, when you see them either reperfuse on their own or reperfused, in fact, the majority of patients with acute coronary syndrome do not have a high-grade stenosis after they're reperfused. Okay, so now let's get back to this idea. The total plaque burden is the best gauge of your risk for acute coronary syndrome. Okay, why is that true? Because you do not need a stenosis, and in fact, a majority of patients who suffer ACS will not have a stenosis. Okay, so any of these plaques are potentially vulnerable. Any plaque can rupture. Any plaque can cause acute coronary syndrome. And in fact, I told you there have been over 1,000 peer-reviewed articles on calcium scoring in the last decade alone. Okay, more than 1,000. And basically the bottom line, the single thing that you can take away from this today is that the calcium score, or the surrogate marker for your total plaque burden, is the single best predictor long-term of you having ACS. The single best predictor of your long-term risk of having a heart attack. Okay, but now what I told you we were going to talk about isn't predicting a guy's risk of heart attack 2 years ago. What we have in our office today is a gentleman with chest pain. Okay, and so how does calcium score have anything to do with this guy who's acute, has acute symptoms? Well, in fact, there's actually some pretty convincing literature that shows that the calcium score might be helpful in the symptomatic patient as well. Not only in predicting long-term what's going to happen to him, but whether he has a stenosis causing angina right now. And actually, the South Bay group in LA out of UCLA, Dr. Budoff's group, and also Dr. Nez in Munich have looked at this extensively. What they both did was a very similar study design. Basically, they took patients that had been completely worked up by cardiology, either outpatient chest pain or inpatients through the ED. They've been completely worked up, had whatever pre-cath workup. All patients were sent to cath. And what Drs. Budoff and Nez did was said, well, wait a minute. We have this test we can do. It'll take about 2 minutes. If you'll just go on the scanner, do a breath hold, we want to get a calcium score before you go to the cath lab. Okay? And then they looked at the calcium scores and they said, how did that correlate with a positive or with a angiographic findings? And basically, they both had very similar conclusions. What they saw, and again, huge, big studies, 1,800 plus patients in Budoff's study said that if you had no calcium, your risk of having a positive angiogram was 4%. Okay, and Dr. Nez basically saw a 0.7% positive rate in patients with no coronary calcium at angiography. And I will tell you that I've been doing this since 2004. We have not yet seen a patient since 2004 with no coronary calcium ever proven to have significant flow-limiting stenosis so far. 0. Okay? Now, the other thing they did was say, well, that's very sensitive. If we just use 0 as our cutoff, that's very sensitive, but it's not specific. I mean, there are a lot of guys who have plaque who aren't going to have a stenosis. So they just started playing with the numbers and said, well, is there some point, like crossover point, where we could get reasonable sensitivity and specificity? Okay, now I want you to look at this slide and pretend for a minute. You have a patient in the emergency room. Patient in the ED with chest pain, and I told you that you can only have one test, and that's a calcium score. And I've told you that if the calcium score is less than 90, you're going to call it negative, and if the calcium score is greater than 90, you're going to send the guy to cath. Okay, and that's the only test you get. Okay, and I pooled here the Nez and Budoff data here, over 5,000 patients. And what they found was that if we use 80 to 100, that the sensitivity and specificity of calcium score for that patient population did extremely well when you compared it to what we normally do, i.e. exercise SPECT or stress echo. Very similar sensitivity and specificity. And in fact, in 2006, the summer after I was here last, the American Heart Association guidelines for CTA actually reached the exact same conclusion. Basically, they said that CCS could be a reasonable idea in someone presenting to the ED with chest pain, and they said that if the score is 0, the negative predictive value was incredibly high. Yes?
Excuse me, how often is the CCST recommended?
Yeah, we're going to talk about that, but the bottom line is most of the time. In fact, about 60% of the patients that we see referred to our lab have no calcium. Calcium score is 0. And I was actually at the 05 AHA meeting down in Miami when this came up, and it got panned because everyone said, oh, that's not real world. Most patients are going to have calcium. This isn't going to have any utility at all. Well, I can tell you at Wake Med, that's not the case. We've now done, I'm going to show you the data, but in every study we've looked at, between 55 and 65% of the patients referred to us have no calcium, nothing, 0, and not one of those patients has ever been shown to have significant coronary artery disease. Okay, and what did they say? They said in direct comparison studies, calcium scoring has been shown to be comparable to nuclear exercise testing. This is the American Heart Association guidelines, 2006. A low calcium score precludes the need for myocardial perfusion scanning, and nuclear testing is probably inappropriate if the calcium score is less than 100. Okay, so coronary calcium scoring. Remember though, it's better than the fact that it predicts whether you have an obstructive disease because it does something else. It also predicts your long-term risk of having an ACS. Remember, not only do I have an incredibly high negative predictive value when the score is 0, but I tell patients, and we dictate this in our reports, your likelihood of having coronary ACS in the next year is 0.1%. And that holds for the next 3 to 4 years. So not only do I predict their probability of having a stenosis today that needs addressed, but I also predict their long-term likelihood of having acute coronary syndrome. And again, as the score increases, their risk, future MI risk goes up as their plaque burden goes up, as we've discussed. And remember, I want you just to realize that the ATP NIH guidelines suggest that if your risk of ACS is greater than 2% per year, you're high risk. High-risk patients have an annual risk of greater than 2% per year, okay? Okay, so that's calcium scoring, okay? That's what we do first. The patient comes to us, they get the calcium score done first. Okay, then we move on to part 2 of the examination. Okay, the second part of the exam, again, coronary CT angio, and this is what they always show on the news because it's, you know, the images look kind of sexy and everyone says, wow. What is it? Well, what we do is we give the contrast. We get very high resolution images. We feed it into a computer, and the physician renders these images. Basically, I sit at the computer, and I take the slice data from the CT out, and I can get very high resolution images of the coronary vessels. What am I trying to do? I'm trying to be a surrogate for angiography. Basically, give you the same kind of images you would get if you went to the cath lab. Okay, and does this work? Well, if you look again at the American Heart Association guidelines, again, they actually split it into the older generation scanners and the new generation scanners. If you look at their for the most recent 64-slice scanner, basically what they saw was incredibly high negative predictive value and very good sensitivity. And I will say that at our lab, we have matched these numbers. We do not match the specificity, and in my opinion, at least if I'm doing your study, I think the specificity is lower. What we find is that we tend to overestimate the degree of stenosis, and specificity numbers are more like 50 to 70%. In other words, we're much more likely to overestimate disease than underestimate disease. But I agree wholeheartedly that the negative predictive value of a CTA is incredibly high. Okay? And AHA said, quote, all studies have convincingly demonstrated a very high negative predictive value. Normal CTA allows a clinician to rule out disease with high reliability. And rule out, it may avoid invasive angio. Actually, I would take that a step farther. What I would like to see ultimately happen is it avoids admission, specialty consultation. I mean, the costs are multiple when a patient comes to the ED. And we're starting to look at that. I have a technologist who's now starting an IRB to look specifically at the costs of patients admitted for 24-hour observation admission, which would be kind of the standard practice for chest pain in this hospital. Okay, and they said CTA is reasonable. Okay, so again, there's so much confusion about this. When someone comes to my lab, they're getting 2 studies, a calcium score and an angiogram. Calcium scoring, again, a score of 0, very, very high negative predictive value, and MI risk going forward the next 3 to 4 years, incredibly low. Okay? High scores have a significant probability of disease. They also are high long-term risk. Okay? Coronary angiography by CT, again, very high negative predictive value. We believe that it sometimes overestimates, that you're much more likely to get a false positive than a false negative. Yep. Why? Well, there's a couple reasons. One is if you look at actually the resolution of a CTA, it's not even close to a DSA. So in other words, our images, if you look at, they're blurrier. And what happens is, and the vessels are very small, our pixels are big. So a matter of 2 or 4 pixels can make a lesion, you know, if it's partial volume average, can make a lesion that's really 40% look like 70%. It's not that there's nothing there. It's just that lesions that may not be hemodynamically significant at the cath lab look more worrisome on the CT. The other problem we have is in patients with very high calcium scores, the calcified plaques actually cause a phenomenon called beam hardening artifact. And those artifacts tend to bloom away from the calcium and make it look bigger. So what happens is you're seeing an artifact that's artificially making the stenosis look worse than it is. Okay, so I would, at least in my experience, I think that they're too optimistic about incredibly high specificity. But again, I hope by the end of this hour, what I want you to take away is being able to exclude disease is the whole beauty of this test. I mean, and we're going to talk about that some more. Yes?
I was thinking about the calcium scoring and its number one predictor. I could see how it could even be a better predictor than current catheterization.
It is. It is. It is, and I'm going to show you a case in a little while where the guy's calcium score is over 1,000 and he has a normal angiogram. Yeah. No, only 20% do. Only 20%, but we know through many studies that about 20% in all patient populations calcify. Okay, there's some controversy that blacks may have a little less than that. The thing to remember here, though, is before you have a heart attack, you usually have hundreds of these lesions. So the fact that only 20% calcify, it's a rare phenomenon that someone either has a stenosis or acute coronary syndrome before they have any calcified plaques. It's not zero, at least, but although we've never seen it, it's not zero, but it's rare. Okay, so I want you to realize we're doing two tests. They both have very high negative predictive value. They both are performed on almost all patients, and the results are complementary. I think you have additive safety when both of them are negative. Yeah.
The calcium scoring is so good at predicting a negative predictive value in people with a zero. Why bother doing the CCTA?
Yeah, I think it's hard to justify. We have a couple issues, is that there's no one who's willing to do it. I mean, I don't know why. I mean, the data is out there, and in my own personal experience, I've never seen a case. And in fact, every case that I've called positive with a calcium score of 0 has been, 2 or 3 that I said, look, it looks like there's something. We're always proven wrong. I mean, it's artifact. In fact, last year we did 107 cases, had a calcium score of 0. Okay, 105 of those we read as completely normal. We find no plaque, and only 2 patients we thought we saw minimal soft plaque. It's very uncommon to have a stenosis, and I can tell you, as soon as I see the calcium score as 0, and I'm reading the CTA, I kind of breathe, I kind of exhale, because I know this is going to be a slam dunk, easy, because it's so rare that you see anything.
So you think just that it's too new, and as people get more confident?
It's not new, though. Those articles are 10 years old. I mean, we have 2 problems. We have 2 problems. One is, I don't have other centers who are doing it. The other problem is that it's not reimbursed. So I can get reimbursed if I do the angiogram. I can't get reimbursed if I do a calcium score. Okay, so let's move on here. So the question is, again, I'm making this sound like the best thing since apple pie, but I want to be clear that it is only indicated in certain patient populations. Okay, and basically what we want is we want a patient that, first of all, that we can get good image quality. And that means usually, cooperative, can hold their breath. And second of all, we want a patient that doesn't have tons of calcium, apropos your question. If they have too much calcium, then I can't read, I'm calling all kinds of stuff. So I want to choose a group of patients that's likely to be negative to begin with. And then the second thing I want you to understand is negative is incredibly helpful, because if I could rule the patient out, they could go home and not get any more workup. If I have a positive exam, have I really done that patient any good? And I would argue probably not. Because think about it, I've seen a stenosis, I still don't know whether it's clinically germane to that person. They probably still need perfusion scanning to see if it causes ischemia, A, and B, I can't treat their stenosis like they can in the cath lab. So what I tell people when I see residents asking me about it was, I say, I've done something great when I get a normal, a calcium score of 0 and normal, and that person has no further workup. When I see a high-grade stenosis, yeah, I beat my chest, I bring these beautiful images like you're going to see at a conference, but have I done that patient a favor? No, probably not. All they did was get an extra charge, extra radiation, extra contrast dose. So you want to pick patients that you have a high likelihood of being negative, because those ones you have a chance to hit a home run. Okay, so how would we use this in real life? Well, this is a real patient from my lab. It's Friday afternoon at about 3:30. Okay, the patient comes in with risk factors for coronary artery disease. Okay, she's in the emergency room, and it's kind of late in the day to get an add-on stress test at 3 o'clock. So they said, you know, we don't really want this lady. She's going to have to sit here till Monday, 3 days in the hospital. Let's call Douglas and see if maybe he'll take her in and we can get her done. So again, she has risk factors. She had some kind of squirrely symptoms. Maybe, you know, there were lots of confounding. Her initial workup is negative. So we take this patient, again, a real patient last summer from my lab on a Friday afternoon to the CT scanner. And basically we do a CT scan, right? CT is a bunch of slices. I get the whole body. It's a CT. It's not magic. Okay, these little angios don't fly out of nowhere. It's just a regular old CT. But we put that into the computer. Okay, and then I can put that in a 3D rendering program, and we can actually pull the heart out of the chest, okay, using this 3D stuff. And we can actually get pretty good images of the heart, and then I actually subtract away the heart to leave us with pictures of the coronary vessels. And this lady has a normal exam, okay? Normal. Score 0, normal, and then basically she got sent home. She went straight from the ED to home, okay? And what I want to impress on you is that the negative predictive value of that exam is incredibly high. And what I have done for her is that I've predicted that she has very little risk going forward 3 to 4 years of having ACS. And in fact, I dictate in my reports no more than 0.1% per year. Okay, so now let's just think about that in terms of applying this across the system. Okay, heart disease is the most expensive diagnosis in the country, and it's estimated that more than $10 billion a year is spent on just these overnight chest pain OBS. And what we found from our research, which I'm going to show you in a minute, is that a majority of these patients are normal. They have nothing. Their CTA is normal, their calcium score is 0. And also what we find is that less than 10%, in fact it's about 5, actually end up getting some acute intervention. So we admit a tremendous number of patients that are normal, and the vast majority do not need any acute intervention. So what I pose to you is, if this were available 24/7 so that every patient that met our criteria went straight to CTA, we would save an unbelievable amount of money. Okay, so now let's just review our experience. And this is kind of a slide for myself. I was trying to figure out how far back did this thing go. And actually, this is the first scan that I can find that I ever did, back in 2002. And back then, we've now gone about 8 iterations of software and about 4 iterations of scanners. And in fact, for those of you who don't know me, I'm actually trained as an MR imager and was trained to do cardiac MR. And one of the big referrals for cardiac MRI back circa 2000 was for anomalous coronary artery to trace the origins. And these exams were very difficult on MR. We had to use what's called a navigator pulse sequence. A lot of times failed. And you dread it. You saw one on there and you just kind of moaned because you knew you were going to be at the scanner 2 hours. So we kind of got this idea, could we start off doing these cases by CT? And even back in 2002, we were kind of shocked. Yeah, even on these scanners that were so slow, the patients had to hold their breath a minute. We were able to get diagnostic images and show, in this case, it's an anomalous left arising from the right coronary artery. So a little while after that, we formed actually at that time, it was called the Cardiovascular Research Imaging Group. It was kind of fancy term for like 4 or 5 of us who were just kind of thought this was kind of cool. And we kind of started getting together saying, well, you know, we think the CTs are going to get better, and we need to start planning for this because 3 or 4 years from now, this thing's going to be awesome. And in 2004, we got our first 16-slice scanner. So we went from 4 to 6 to 8 slice, then to 16. And at 16, now the breath holds were reasonable. Our images were good enough that we could routinely scan the heart. And at that time, basically, I would go up to the cath lab. We decided, well, let's see if this actually is going to work at all. So I would actually go to the cath lab and beg people every morning if they would please, after they got their cath, come down and let me do a CT on them, because we just wanted to see, would this work? And we had done about 20 volunteers, and we had gotten pretty good results. And so these are some of the first images that we got. Again, were about 3 software iterations and rendering after that up to today. And we've gone from 16 to 40 to 64 slice CT. So we're 2 hardware iterations and about 3 software iterations removed. But what we saw is, yeah, if you pick cooperative patients, you could see the coronary vessels pretty good, especially the proximal ones. And we could see even things like soft plaque. Here's a guy who has left main, a little soft plaque here. And then, like I said, we compared 19 patients who went to cath. Here's a patient, with LAD stenosis, and that's my render. Again, these are circa 2004 images. Circumflex stenosis, again, diagnosed by CT and cath. And what we found was, indeed, that our negative predictive value, again, on the 16-slice CT, was very good, that you could exclude patients having significant coronary disease. Then we got, in 2005, we did 2 more IRBs, because I got on, like what you were talking about, I got on this thing about, geez, these patients, a lot of these patients, I mean, I had no idea that 60% of the patients were going to have no calcium. And we started realizing that we never saw anything when they had no calcium. So I said, well, let's kind of look at that. So we looked at over 05 and 06, we enrolled patients from the OBS unit and also some outpatients. We said, would you be willing to get a calcium score? Some of them also got CTAs, but a lot of them just got calcium scores, and then we would compare that to how they did on their stress test. And again, about half were outpatient referrals, about half were inpatient. And what we found was 64% of the patients had no detectable plaque. Okay, and more than half the patients in this study, I think there were 10 positive stress tests, or more, 10 or like 12 or something, I don't know, 11, 12, but more than half of those who had a positive stress test had a calcium score of 0. Okay, meaning they probably had nothing. In fact, there's been a good article done on that about 5 years ago that showed that if you had a positive stress test, then got a calcium score, and then went to cath, your risk of having a positive cath was 1.5%. And again, I want to tell you, since 2004, we have never seen a patient proven to have significant disease that had a calcium score of 0 so far. Okay, and only 5%, I think there were only 3 patients out of that 55 that had significant disease, and lo and behold, they all had a negative stress test, but all of them had significantly elevated calcium. And even more concerning to us was that, of the ones that we saw that had significantly elevated calcium, most of those patients have a negative stress test. So the issue is there are a lot of patients that basically have a full workup, 24-hour admit, they have a negative stress test, and they go home, and in their mind, they're normal. Well, the bottom line is a lot of those patients have significant plaque burdens. Okay, and here's just a case example. This is a 52-year-old guy. He had some risk factors. He had overnight admit, the typical workup, EKG, lab stress, all normal. He's discharged to home, and I kind of caught him on the way out. I asked him if he would enroll in my study, and he said yes. And lo and behold, his total plaque was, I think his calcium score was 1,080. Okay, 1,080. And he had a high-grade distal LAD lesion, and even in retrospect, I think his stress cardiolite is normal. I mean, it's normal. It's a normal exam. Okay, so, and there's this angio correlation with what we saw, a 3D render. And I think even more important than the fact that he has a high-grade lesion in his distal LAD is that his risk of acute coronary syndrome is more than 20 times a guy with no calcium his age. And his risk of dying is more than 12 times in the next year a guy with no calcium his age. And you have no, I don't even care so much that we miss the 90% distal LAD that they're probably not going to stent anyways because it's out at the apex. But the bottom line is that guy has no idea that his risk is unbelievably high going forward the next 3 or 4 years if we don't do the calcium score. And again, I want to reiterate, more than 80% of the patients in our research studies that had significantly elevated calcium had a negative stress test. And here's what you were alluding, someone was asking me about before. Well, does a cath predict your plaque burden? And I would say a lot of times no. I mean, this guy, this is one from one of our research studies, has a calcium score of over 1,000, and I pulled his cath note. It was read as minimal disease. His calcium score is 1,100. His risk of MI is more than 20 times a guy his age with a calcium score of 0. His risk of death is more than 12 times a guy at his age with a calcium score of 0. Okay, so now let's fast forward. I showed you kind of those lousy images on the 16 slice. Now what do we see in the, in the last year or so? Just a couple of quick examples before we wrap up here. This is a guy who had a negative stress test. He had persistent anginal symptoms that were sounded like angina. Here again is my 3D render, and here's his correlative cath, just to give you some idea of what we see versus what they see at DSA. Another patient who came from the outside. This guy had pretty good anginal symptoms. He actually came from a small rural hospital and had had an abnormal stress test. And he got here and they decided, well, I don't know if we trust that test, so they decided to repeat it. And his repeat test was normal. And they said, well, we kind of think you're okay. I don't think you need go to cath or anything. And the guy said, well, I'm kind of uncomfortable with that. I got one stress test positive, one negative. Is there anything else we can do? That's how he ended up at our lab. And basically, he had a calcium score of about 300. He's got this circumflex lesion. And again, just to give you some sense of what we see, in our lab versus what the angiographer is seeing. And again, they ended up not stenting that circ lesion. That's fine. The only issue I have with it is, again, this guy's plaque burden is in the 95th percentile for age. His risk of MI is more than 10 times a control patient with no calcium at his age, 10 times. And I would argue that that guy has no inkling of that unless you do the calcium score. Okay, and here's some, just another more complicated case. This was a patient referred to me who knew that he had an occluded circ and he had a large OM that had been stented. And they couldn't, at the prior cath, find his RCA, and so they had said, we need to recath this guy because we think he has a repeat stenosis, but we couldn't find his right. Could you please try to find the right before he goes to cath? Okay, so here again, we pull his heart out of his chest with a 3D program. We isolate his coronary, and again, notice the occluded circumflex there, and then we're going to show you here his recurrent stenosis just proximal at the leading edge of his obtuse marginal stent. Okay, but then that really wasn't the question. The question was, well, where was his right coronary? And actually, we discovered that he had an anomalous kind of hypoplastic right arising from his left coronary cusp. That was why they were having trouble demonstrating it at cath. And again, here just to show you what they see in the cath lab versus what we see by CTA. Okay, so now let's just finish up and look at what we did last year. Again, 223 patients, clinical patients, referred to CTA at WakeMed last year. About 85% are what we are talking about. Patients with chest pain or shortness of breath who don't have known pre-existing disease, and can we rule them out? Okay, so all these other things we're going to forget about. And we're going to focus now on these 189 patients that we did in 2007. What were the results? Well, this slide's a little busy, but I think the gist of the issue is that I want people to come away with is that a majority of the patients sent to our lab have a calcium score of 0. In fact, 57% of the patients last year had no calcium. And of those, 106 out of 107 had a negative CTA. We had one patient, because we lost the gating, failed. It was non-diagnostic. So again, no patient with a calcium score of 0 had a positive CTA. Again, we have never seen yet a patient with a calcium score of 0 be proven to have a high-grade stenosis. Again, if you look at patients, as we would expect, we look at patients with intermediate calcium scores. Again, we start to see the proportion of CTA-positive patients go up, And as the calcium gets significantly elevated, a majority of the patients have positive CTAs. Okay? It's like I said, as the calcium score goes up, it gets harder for us to predict, because of more blooming, more plaques that we have to look at. And actually, I think a significant percentage of these are false positive. So, but what was impressive to me and has been constant is that 55 to 65% of any group that we've ever looked at have 0 calcium and a negative CTA. And that's held since 2004. And B is we do a pretty good job on patients with low calcium of seeing vessels well and being able to either rule in or rule out disease. Okay, so I want just to take away, 85% of all the patients referred to our lab have a negative CTA. 94% of patients with a calcium score of less than 150 have a negative CTA. We have never seen a patient in 4 years with a calcium score of 0 proven to have significant disease. Okay, now the other thing is, getting back to this idea, we show these like wild, spinning hearts and these beautiful 3D images, but I want to get back to the fact is CT is CT. So you see all the things that you would see on a chest CT, on a coronary CT. We see the lungs, we see the bones, we see the mediastinum, and we look for other things. And what we found, and this has been pretty constant and actually correlates well with the good data out of the University of Michigan, is about 1/4 of our patients will have some non-coronary finding that's potentially significant. And in a minority of patients, we also find diagnoses that may explain their chest pain. Okay, and these are from last year, just the list, things that we saw on scans that potentially could have caused the chest pain that, other than coronary disease. Okay, and then the other thing is, because we get a calcium score, we accurately, or I think more accurately, predict your long-term risk of ACS. And these are the things that I think are significantly better than what we're doing now. Basically, we can make alternative diagnoses, and I think that we more accurately risk stratify people going forward in the future about what their true ACS risk is. And this is actually an old case, but it was my favorite for the non-coronary. This is a patient who came with chest pain, actually had pretty normal coronaries, but had a big sinus of Valsalva aneurysm. And lo and behold, their chest pain was undiagnosed achalasia. Here, this huge dilated esophagus with an air fluid level. And by the way, there's a 15 millimeter lung mass in the up superior segment of the right lower lobe also. And here's just another one. I was like struggling to show the PDA on this patient, and it kept kind of, something out of the corner of my eye kept bugging me. And I realized, oh my gosh, there's a dissection flap in the aorta. So this is a patient with a type B dissection, again, potentially causing their symptoms. So I hope I've made my point, but what I would say is why should CCS and CCTA be the first imaging test in appropriately selected patients? Again, patients that are likely to get a negative exam. Well, I would argue is that we've shown this in all our studies. The majority of the patients are normal. If I could do this 24/7, take people straight from the ED and send them home because they're normal, then we preclude the need for consultation, admission, or any further evaluation. Potentially could save an incredible amount of money. Okay? I think it has a negative predictive value is higher than stress testing. Okay, the published negative predictive value is about 85% for stress testing, and we've seen it over and over. Patients with significant disease are picked up by the CT. And I also think that calcium scoring is the single best predictor of your long-term risk of having ACS. I think that, there's tons of data out there that stress testing is not a sensitive predictor of your long-term risk of having ACS. And then again, ancillary benefits, we can see other things besides the heart when you get a CT. Maybe you have pneumonia, maybe you have a dissection. And again, the challenge for us as providers is that we have to be committed. It doesn't going to save the money unless we're willing to be committed to do this around the clock. and give high-quality interpretations at all times, just like we do every other CT test in this hospital. So that's the challenge for me and the other people who are going to provide this, is that we have to be committed. This isn't something that you get 9 to 5. It's something that we're going to do 24/7, 365. And when should it be the first test? Well, again, I think, we're trying to screen for patients that have a significant possibility of having a negative test. The reason why is, again, when I get a positive, I usually haven't helped anything. A lot of those patients with a positive CTA still need perfusion imaging, and if they have a stenosis, they still need to go to the cath lab. So you want to pre-select a population that has a high likelihood of having little or no disease. So what if we did this in the ED? If you used our data from last year, basically what we would see is 56 or 57% of the patients would have a normal CT and no calcium. I feel like those patients can be discharged home. In fact, I dictate on my normal exams that my study excludes disease with a 99% predictive value, and that their risk of heart attack in the next year is 0.1%. I put that on every single one of my normal dictations. What about the patient with intermediate who we think has a negative CT? My gut feeling is a lot of these patients can go to home too. Many of them have minimal disease. But what I'm recommending now is that if they have anything and you don't feel comfortable, we'll consult cardiology. Get the cardiologist looking at these studies. I mean, a lot of them have minimal intimal plaque that's minimal. Let them start looking and getting a feel for how good some of the stuff. A lot of people have never seen these images. I mean, when it's done right, it's diagnostic. So I would recommend, if it's normal, I'm happy with that. I think that patient can go home. If they have any disease and you're not comfortable, well, then they can be seen by cardiology. Again, if you have a positive CTA, then obviously we're worried that you have flow-limiting lesion. You're going to need a full workup. And we are, at this time, at least on acute chest pain patients, recommending that if they have a high calcium score, that we don't even do the CTA, that we, instead of take the risk, since a majority of these patients are going to have a positive CTA anyways, you're just going to radiate them, give them contrast. So what we're advocating is that you just stop on those patients after the calcium score and don't even proceed. And then those patients would get the normal workup. And Glenn Coates made this slide for me. I thought it was kind of cute. So 0 is incredibly powerful. A calcium score of 0 is an incredibly powerful bit of information. And I think at a minimum, we could see, at least in selected patient populations, the number of admissions drop 50%. As I think as people get more comfortable with this, we're going to see the drop in the 70% range. Questions? Yep.
How far are you from getting this reimbursable? And then, what is the cost to the patient?
Yeah, that's a good question. Most of the time it's reimbursed. It's certainly, I can't remember it not being reimbursed in an inpatient ED population. If you have to get pre-authorization, it really is variable between insurance. We're seeing most, at this point, Medicare covers it and most insurance, but there are sometimes, if you try to get pre-authorization for an outpatient study, it can be difficult. Now that, we're talking about a combined calcium score CTA together. If we talk about calcium scoring, there's almost no reimbursement for that. So right now we're advocating, we do a lot of patients in our office for asymptomatic screening. If you have risk factors, we do a couple patients a day who pay, for that test it's $350 cash. We just do a calcium score, and it's specifically for ACS prediction, future prediction. And those patients pay cash. We're talking about today an asymptomatic patient. Again, if you're talking about ED, OBS, almost all of those are going to get reimbursed. Unless we stop after a calcium score, then I guess I'm going to have to eat those. But if you do a CTA, most of those will get reimbursed. Yes?
When you 24/7 coverage, I imagine the radiologist would have physically present.
Well, the problem is we have, I'm glad Chris Green walked in, because we have limited people that are skilled. These 3D renders look nice when you have people that are very skilled doing them, but it's not, not anyone can do this stuff. So we have it's going to be a process, I think, over several years where we train people to get them up to speed. But yes, I mean, the real answer to your question is, yeah, our technical wizardry is such that I can do these, I can make those images, this image right here, I can do that at home right now. I can pull that from Wake Med into my study at home and make that image. Yes. So it can be done. I think we can overcome. I mean, what I've been telling people is, look, we can't proceed unless we have a steady flow of patients during the day. Once that happens, then I will be the first one to champion that we extend these hours to the weekends, then to the evening. But this is a process. I mean, right now the volume is not enough for me to keep enough people highly skilled and trained to provide this service. I mean, Chris and I cannot provide this by ourselves. We need technologists at Western Wake, at Northern Wake, at Briar Creek. I mean, it's a huge undertaking to get these people up to speed, and it's a several-year project. And what we are advocating now, I mean, Chris just actually made up a call schedule. What we said is, look, if we're only doing one case every other day, then we don't have enough cases to provide more than Monday through Friday coverage, because I can't train. I mean, we have right now 4 radiologists trained and Chris and a couple cardiologists who are showing interest and may get on board. But if we're really going to do this like it needs to be done, we need a lot of people. And that's going to be a process, I mean, a couple-year process. I mean, right now, what I can tell you is if you order a case between 7:30 a.m. and 4 Monday through Friday, we'll get it done in a couple hours. But I can't extend that to the weekends or the evenings until we're seeing a steady stream of patients during daylight hours.